Good day and welcome to Basic EMS 12 Lead and STEMI Identification, when EMS truly makes a difference. This is Sean Halsman, paramedic and education guy. This is a 12 lead overview and also a module we are creating to help with STEMI identification. It's something we've been doing for a while in the field, and if you're not comfortable with it yet, you should be, and this will help you to be more comfortable when you're looking for STEMI and other specific findings on an EKG that would tip you off that there's a problem with your patient. If you are looking for rhythm recognition, that will be a separate module from this one. This one is strictly going to go over 12 lead and the STEMIs that we see in the field. 12-lead technology is important. We have been doing this now for over 10 years, and it's important for us to be able to read the 12 leads, especially in the face of STEMI. The patient care we're giving now demands that we're able to read these 12 leads and that we have some background in cardiology. And our job does not get easier as medics as we move on. The expectation of our knowledge in anatomy and physiology is something that increases over time, but we will have to learn how to read these and use them to give proper care to our patients. If you have not had an opportunity to go to the cath lab, you are missing out. This is an amazing procedure that I've seen several times, and many of you have been able to go in with a STEMI and go up to the cath lab. But we are finding in the field 12 leads with STEMIs. We are initiating these cath labs from the field with our report and our 12 lead, and that's calling into action tens of thousands of dollars worth of staff that are going to come in here and perform these procedures, the percutaneous coronary intervention, where, as you know, they go right up into a blood vessel and open it up. And this is a diagram of just one of those things. Here you have the coronary artery that's got 100% blockage right here, so this is a person who would be probably suffering STEMI, and after percutaneous coronary intervention, you can see that the blood flow has been restored to this vessel, and you are getting lots of perfusion back to the heart here. So this is something we're going to initiate back in the field, and this is something that we're going to diagnose in the field with a 12-lead EKG and then get the hospital updated so that these staffers and interventionalists can be ready for us when we get there. It really is pretty amazing that we're doing this stuff now in the field. So our successes in our patients' lives depend on our ability to demonstrate proper ECG capture, interpretation, and transmission skills. We owe it to our patients to be able to capture a 12-lead properly, to read the 12-lead properly, and to get those patients to the most appropriate care facility. Sometimes, based on condition, the patient's most appropriate care facility will be the closest facility. But if we have somebody with an acute coronary problem and we're able to get them to the PCI center safely and effectively, that is going to be the most efficient care we can give to our patients. So the goal for this presentation, by the end of this first part, you should be able to describe a normal conduction of electricity in the heart. We're going to go over the cardiac conduction system and different waves on the EKG. Identify components of a standard ECG, so your PQRST waves. That's mostly review. Demonstrate proper electrode placement. So we'll talk about limb and precordial leads. We're going to explain how leads work, so you have a little bit more of an understanding of what you're seeing. Explain the process of obtaining a quality ECG. And then we're going to describe the physiology of an AMI and talk a little bit about the main coronary arteries. So that's what we're looking for in this section. In the second section, we'll be talking about J-point and STEMIs and how to discern a normal 12-lead EKG from one that is not normal. So let's review the cardiac conduction system. Here in the upper right-hand corner, we have a little animated GIF file here. It's showing us what's going on in the heart over time. But remember, we have a super highway, you could say, of electrical pathways in the heart. All of the heart tissue, as you know, can accept a current and can transmit a current. But we have these specialized tissues here in the conduction system that are the main pathways, and they are better and faster at initiating currents. So remember how this works. We have your SA node up in the right atrium, and the SA node generates your beats. And remember, the intrinsic firing rate of the SA node is somewhere in the realm of 60 to 100 beats per minute. And that's a normal heart rate. So your SA node is going to initiate a beat. That beat is going to propagate throughout the atrium. It's going to cause the atrium to squeeze down and pump the blood into the ventricles. So your atrial contraction is going to pump blood into your ventricles here. The next thing that happens is you have the electricity transmitted through to your AV node. Now remember, the AV node has a built-in delay in there, and what the built-in delay is designed to do is give the atrium time to fill the ventricles, so you're not pushing blood out of the ventricles just yet. It's a very small delay, but we are looking at the AV node here, and the AV node can also generate beats, but it's a little bit slower. So your AV node can generate beats, remember, between 40 and 60 beats per minute. So if you have some loss of your ability of the SA node to do stuff, then you're going to have your AV node that kicks in. Then we get transmission down the left and right bundle branches and up through the Purkinje fibers, and that causes a ventricular depolarization. The cells in your Purkinje fibers can also create a beat, but those are the slowest ones. So Purkinje fibers, remember, you're looking at 20 to 40 beats per minute. So we need a pacemaker in the heart, and usually it's the SA node, and hopefully it's the SA node, but if it's not, then we have to move on and let other areas of the conduction system happen. Following the depolarization of the heart, we get repolarization, and it all starts over again. So here's our atrial depolarization once more. Just squeezing the atria to push blood into the ventricles for preload. Then the ventricles transmit electricity down through the septum and then back up through the sides of the heart to squeeze the blood out through the main blood vessels, your aorta and your pulmonary arteries. And then you have repolarization. The repolarization is not a reversal of the electricity, but I just use arrows here to indicate that we are getting reset for another cardiac contraction. Much like cocking the shotgun after you take your first shot, you're getting the next bullet ready to go. So total conduction system looks like this, and then we have a tracing on the ECG. So before we go into tracings, let's review a little bit about the paper that we use here, or the squares. Remember, one big square here is equal to about 0.2 seconds. So this is one big square. It's 0.2 seconds of beats. So if you want 1 full second, you're going to look from here. This is going to be 0.2 seconds, 0.4 seconds, 0.6 seconds, 0.8 seconds, and this is 1 second. So 5 big boxes is going to equal to 1 second. This is going to be important when we talk about determining rates without staring at the computer numbers, because they're not always accurate. And then these little boxes are 0.04 seconds. So 0.04 seconds is a short bit of time, so 5 of those makes up 0.2 seconds. And then remember your amplitude here. Amplitude is going to be very important when we start talking about ST elevations, but your amplitude here is about 1 millivolt for 10 boxes, and that'll tell us if we have ST elevations or depressions when we reach that point. What's a lead? Let's talk about leads. So each lead basically takes a picture, if you will, of the heart from a different angle. The leads consist of one positive electrode and a negative electrode, or in some cases they use a couple of stickers to make one positive and one negative electrode. When electricity travels towards the positive electrode in a lead, you get an upward deflection on the ECG. If the electricity is traveling away from the positive lead, you get a downward deflection. And if the electricity is traveling perpendicular to a lead, you get a biphasic or an equiphasic deflection, which means it goes up and then down. All right, so let's think about this as a football play. The quarterback hands the ball off to our running back here, and the running back runs a running play up through the middle and into the secondary. It's just one play. All right, this is one play that we're looking at. However, in the case of various leads, we're looking at this play from different angles. So if you are in the stands somewhere up in this area, over here, all right, we're going to call you the positive electrode on your lead. If you're in the stands, you are watching the electricity pass you perpendicular. It's going to start on your left side, and it's going to pass across and go to your right side. So from your perspective, this play is running from right to left. And on an EKG, what that looks like is biphasic or equiphasic. So we have up and then down and then back up. All right, so that's going to be a biphasic play. If you're back here in the backfield, or you are in the stands in the end zone, they're looking this way, and you're the positive electrode, all right, which way is electricity going compared to you? Well, it's going away from you. So in that case, you're going to see this as a negative deflection on an EKG, because the electricity is moving away from you. If you are on the defense team here and you are a positive electrode for your lead over here, then you're going to see the play coming towards you, which means you're going to have a positive deflection on the ECG. All right, so it's all the same play, and it's important to keep that in mind. We're looking at the same play just from different angles, and the reason why we have different shapes on our QRS complexes is because we're looking at this from different angles. So normally we look at lead 2, and lead 2 is a good lead to look at overall because your heart sits in your chest right about here, and it's on a little bit of an angle, and most electricity starts in your SA node and then travels this way through the heart. So the general axis of the heart, or where your electricity goes, is usually that direction. And it kind of follows with lead 2. So with positive lead for lead 2, or positive electrode for lead 2 is down here, and the negative lead is up here, and that's why we have the deflections we have on our EKG. So atrial depolarization in lead 2 causes an upward deflection. It's the depolarization of the atria. It's traveling away from or towards the positive lead down here. So this is your positive electrode in lead 2. Atrial depolarization travels towards that, so you have an upward deflection. It spreads to the entire myocardium. And then you have this little built-in interval here, this PR interval, which we'll talk again about in a while. Remember, that's the delay at your SA node that keeps your ventricles from squeezing too quickly. Then you have ventricular depolarization. So after your pause, you have the electricity going down into the Purkinje fibers, so your left and right bundle branch, and that's going to cause your QRS complex. And then finally, at the end of the contraction, the heart resets, and you have an upward stroke on your T wave here, and this is going to be the heart repolarizing and being ready to fire. So the whole cardiac cycle. All right, here's your P wave, atrial depolarization. QRS is your ventricular depolarization. Important to remember is that this is the duration of the normal QRS, so it shouldn't be any wider than 3 small boxes. And if it is, then we're going to talk about something in a minute that can explain that. But QRS is your ventricular depolarization. Your T wave is ventricular repolarization. Your atria do repolarize, but their repolarization are hidden in the rest of the ECG. There's not a large amount of electricity involved in that. This blue line that just popped up here is your PR interval. PR interval, remember, should be somewhere in the realm of 0.12 to 0.2 seconds. So if it's longer than this, we're going to start talking about our AV blocks, which again, we're not doing rhythms in this presentation, but that would be an AV block. It should be right around that length there. This is an important one that we don't talk about as much until you get into more advanced cardiology for the medics, but this is ST segment. So at the end of your S wave to where your T begins is the ST segment, and then there is this little happy spot right here. This is called the J point. The best definition I have seen of the J point is this, where the QRS ends and makes a radical change in direction. So is wherever your up down of your QRS stops and then starts heading that way again, that's going to be your J point right there. So in this situation, here's our J point where it goes over. J point is going to be extremely important for identifying STEMI when we get there. So keep that in the back of your head. J point is huge. We also have a TP segment, which we're not going to discuss too much, but this is the segment from the T wave into the next P. Right? So this is your whole cardiac cycle together, one beat, P wave, PR segment, QRS complex, ST segment, T wave, and then repolarization, and it starts over again. Okay. This is important to remember. The ECG tells us very little about the function of the heart muscle. All this is talking to us about is electrical activity. Now, we can assume from certain patterns that there is no cardiac function. For example, when we see ventricular fibrillation. That is a disorganized rhythm. It's not going to cause any kind of blood movement, so we can assume that the heart's not pumping properly at that point. However, we can have really decent looking rhythms and still have no pulses in a PEA situation. So ECG is just electricity. All right. There are 12 leads that we're going to go over. The frontal leads, this is the red black and white electrodes, you know, smoke over fire and all that kind of nonsense. This is what the leads look like. So remember, these are just the view of the heart. Lead 1 has the positive electrode on the left arm and the negative electrode on the right arm. Lead 2 has a negative electrode on the right arm and the positive electrode on the left foot. And then lead 3 is basically the opposite, or just about the opposite of lead 2, and it's got the negative electrode on the left arm and the positive electrode on the foot. Now these are the augmented limb leads here, and they call them augmented because they mix together 2 of the electrodes and make 1 to change the plane of the view. So in AVR, your positive electrode gets put up on the right arm, and then it combines these 2 stickers right here and makes this the negative right here. So this is your negative electrode. AVL, just the opposite, right? Positive over there, negative over here. And then AVF makes a negative here and down there. Now, if you think about this, 2, 3, and AVF are all kind of running in the same direction, and that is why we use those 3 leads to identify a certain area of the heart, which we'll talk about in a little while. So limb leads here, the frontal leads. Augmented limb leads are here. That's where the A comes from, augmented. And we use those 3 or 4 stickers that we put on the standard patient to get 6 views of the heart. Your precordial leads, on the other hand, are the ones that cut the heart in half on a horizontal level. So we're looking at horizontal leads here, and these are your V leads. They're the positions that they're supposed to be in, and we'll talk a little bit about the anatomical positions that they're in, but these look at a different plane of the heart. So these are going to look at the plane of the heart that is cutting the body in half this way. Your limb leads look at the front plane of the heart, which would be parallel to your chest. Now, limb leads. Guess why they call them limb leads? Take a big guess. Why do they call them limb leads? Limb leads, they go on the limbs, not on the chest. So we are not putting these on the chest and torso and the belly here. There is a reason for that. If you place limb leads on the chest and belly, you can get false positives or false negative readings on the ECG. And if you don't believe me, I will give you the studies that have looked at this fact. A lot of people don't know this. A lot of people in higher medicine, like nursing, and don't know that either. But it is true. You will still get a recording, but for a 12 lead, you won't get an accurate recording always, and we want to have them most accurate. So for our purposes, we can put them on the limbs there, and you can really use any part of the limbs. Remember, smoke over fire, which is black over red, and then white on the right, and snow goes on the grass. That's the thing. They're all labeled now, so you should be able to read the LA. All right, so traditional placement would call for you to put them on the wrists and ankles. All right, for us, not so easy always. The patient's moving a lot. There's a lot of patient moving there. We don't have the opportunity always to have the patient lay flat for us and not move around. So we can put these on the wrists and ankles and they'll work. But for our purposes, having them on the proximal limbs is okay. So shoulders, upper thighs is fine. We can do this here, but you have to really make sure your patients aren't moving around too much. In the hospital setting, they can lay on a big bed and not move for you. In our setting, we're doing it on a couch or in the back of the moving ambulance, and some of the movement of the extremities can cause artifact and make it difficult to read a 12 lead. This is the anatomical positioning for your stickers or your electrodes for your V leads. So V1 is 4th intercostal space, just to the right side of the sternum, and then V2 is directly across from that on the left side of the sternum. The next one that I like to place is V4, because V4 has a specific anatomical location, and V4 is mid-clavicular line, so there's mid-clavicle right there, and V4 goes there at the 5th intercostal space. And then V3 literally goes right in between V2 and V4. So V3 is just going to be on a line over there. V6 is the next one I place. It is, again, it's mid-axillary line. And then you got V5 that goes between V4 and V6. So these four, V1, V2, V4, and V6 have specific anatomical locations, and then V3 and V5 just kind of fall in between. That's probably the best way to work through the placement of those electrodes. Here's how they look: V1, V2, place V4, 3 goes in the middle, place V6, and then V5 goes in the middle. So that's your placement for your V leads, and those are the colors that they use. Wouldn't it be interesting if they used the rainbow colors in order? Yes. Why do they not do that? I don't know. Remember that all your patients are not going to be Olympic athletes, so you may have to work around patients who are obese and large. Women who have very large breasts, you'll be having a difficult time finding the anatomical locations there. But remember, we're putting these skeletally. We're not putting them in relation to the skin. So somebody who is obese or somebody who does have very large breasts, you're going to have to move that tissue out of the way to make sure that you are putting the electrodes in the places that they're supposed to be. And notice on this patient, they have made the mistake of putting the limb leads on the torso. So again, this is a no-no. Don't do this. This is going to cause you to have issues with getting a exact tracing. All right, guess why this guy is not going to have a good 12 lead right now. All right, unless you have hedge clippers on the truck, we are not going to be able to get these stickers to stick. So it's important for us when we're getting a good 12 lead ECG to prep the chest, shave. There is a prep razor in there. Don't bother using a Bic. If you have a Bic regular razor, it's going to be clogged in about 2 seconds. So don't bother with that. We are going to be having to clear the chest off. And a lot of times also the patients in cardiac difficulties are going to have perspiration. They're going to be sweaty. You're going to have to wipe that off as well. If they've been working outside, it might be dirty. So you need a good, clean, hairless surface to connect your electrodes so you get the best tracing possible. Best position for a 12 lead ECG is again supine or semi-Fowler's. If the patient has shortness of breath with their cardiac problem, it's going to be difficult for us to have them lay back in a lot of cases. So as always with EMS, just do your best. Try to get the patient in a proper position for this, but you may not be able to do a 12 lead without them sitting up. Other big thing, patient needs to sit still. So once you put the leads on, if they're moving around, you're going to get stuff like this. If you look at this ECG, you have these horrible up and down artifact areas. And quite honestly, this is not diagnostic quality. There's no way for us to take a look at this and decide if we have elevations or depressions or if this is just a movement on the patient. So this entire ECG is bad. If you record something like this on your patient, just do a new one. Don't bother sending this to the hospital. The doctor is going to tell you to redo it. You can't see anything in here. The way we do that is have the patient remain still and motionless. Make sure the junction box where the 12 lead cables connect into the 4 leads is sitting in a spot that is not getting bounced around, and have the patient breathe in and out slowly for 10 seconds during the capture of the ECG and move on from there. So let's talk about the major coronary arteries here. There are lots of arteries and vessels in your heart. We'll talk about the main ones. And you've got your left coronary artery right here. So this is one that obviously comes off on the left side of the heart, and that branches off your left ventricle. There are multiple branches there because remember, the left ventricle is bigger, stronger, does more work, so it needs more blood flow there. This splits into your left circumflex artery. So circumflex is going to go around and wraps around to the back side of the heart there. You have your left anterior descending artery here. So there's a bunch of large blood vessels that run into the left side. You also have your right coronary artery. And the right coronary artery comes around and feeds the inferior wall and the right ventricle. Now, you've heard of something called collateral circulation, which means that you develop additional blood vessels to feed parts of the heart, especially if you're getting older or if you have been an athlete, because your heart needs more muscle. So the collateral circulation will sometimes allow blood from one vessel to bring nutrients and oxygen to different areas of the heart that it wouldn't normally feed. You also can have anomalies with coronary arteries. So sometimes a person, for example, will have a circumflex artery and most of the right ventricle is fed by a large prominent circumflex artery. All right, that will be just an example. So these are not always exactly the same, but this is a general pattern of coronary circulation that we get there. Blood flows into the coronary arteries during diastole. So after the beat of the heart and the squeezing of the ventricles during the rest phase, that is when you have blood flowing more passively into the blood vessels around the heart. All right. We talk about acute coronary syndrome, and acute coronary syndrome is basically a set of symptoms that are associated with a patient who is having blockage in the heart. Over time, you get plaque. So you eat a lot of junky food, especially you live in Buffalo here, and you get plaque, and there's a very narrow where area for the blood to move through there. And at some point, the narrowing can clog up totally or just cause enough narrowing that your tissue can't get enough oxygen. That's what causes the chest pain. So when we talk about acute coronary syndrome, we're talking about chest pain, dizziness, sweatiness, all those things that we would associate with a heart attack. Risk factors for this: smoking, obesity, diabetes, high blood pressure, high cholesterol, sedentary lifestyle, all those things that we do in Buffalo during the wintertime because we sit and watch the Bills lose and then we get upset about that, high blood pressure, eat a lot of chicken wings, bad stuff there. So this is acute coronary syndrome, and it means that your oxygen-starved muscle is yelling and hurting. Acute MI is something a little bit different. So acute coronary syndrome is the symptoms that could be cardiac related. Acute MI is when we actually have death of the heart tissue because of lack of blood. Same types of symptoms: chest pain, possibly radiating, shortness of breath, diaphoresis, dizziness, pale skin, vomiting, nausea, all that kind of stuff, and then possibly cardiac arrest. The reason I'm putting this up there is that I want you to understand there is a difference between ACS and AMI. All right, AMI and ACS are not totally equal. They do not equal them. But we're treating them the same way. Nitrates, morphine if we can, aspirin, oxygen if necessary. All right. So it's important to remember that an AMI can present in many different ways, especially in older women. You can have just weakness, dizziness, general illness, altered mental status. So 12 leads are not just for people who have chest pain. In fact, I have made 12 leads part of my normal vital signs on any non-trauma calls. So anybody who's had a dizzy spell, passed out, has any kind of general illness complaint, I always do a 12 lead as part of my vital signs because you'll occasionally catch stuff that you didn't expect there. So when is it appropriate? Any complaints of chest pain at any age or discomfort. Anybody who's short of breath should get a 12 lead. Anybody who's passed out, whether they're awake or not, should get a 12 lead. Any non-traumatic, new onset pain, neck, jaw, shoulder pain, general illness and throwing up, epigastric pain, if they've just used cocaine recently, if they have a new onset dysrhythmia, so the patient's been normal their whole life and then suddenly they're in SVT or they're in VTAC and we break that, you want to look and see what the 12 lead says, and anything else that would be weird to you. So factors or complaints that you find suspicious. I like to have a pretty low threshold for 12 leads, so I'll do them on most patients that are non-trauma. We talked a little bit about the leads, purpose of multiple leads, and basically we're getting a different camera view of the heart so we can see different areas of the heart and know if there's damage. So if there was damage on the front of the truck right here, all these pictures up here would have been fine, and John Speck would have been very happy until he looked at the front, and then he would have seen, oh, there's some damage there. Probably would have started seeing it here. So when we use multiple leads, we're able to look at various areas of the heart and see if there's damage to those areas of the heart. And if we only looked at one lead, we wouldn't be able to see everything. These are your leads, and we're looking for problems. We're looking for problems in contiguous leads. And contiguous leads means that there are two leads that look at the areas of the heart which are adjacent to each other. So this is a bookmark that I've made up for people to laminate. If you want one, you can give me a call. I have lots of them left over there. But basically, if you're seeing damage or abnormalities in lead 1 and lead AVL, that's going to be your high lateral wall. If you see V5 and V6 as well, it's going to be your low lateral wall of the heart. So these are contiguous leads. Inferior wall problems happen in 2, 3, and AVF. Septal wall of the heart, V1 and V2. And then your anterior wall in the front is V3 and V4. All right. So AVR is kind of a goof lead. We'll talk about that later. It doesn't really look at anything specifically, but the rest of these leads are attached. So if we see problems in 2 or more contiguous leads, that is when we're going to be concerned. This is a view of the inferior wall. And remember, inferior wall is going to be leads 2, leads 3, and leads AVF. So those 3 leads are looking at the inferior wall of the heart. This view of the heart is a posterior view. Usually if you see problems in 2, 3, and AVF, you have a blockage of the right coronary artery. So the right coronary artery is wrapping around the heart and coming through here, and you're going to get problems with there. So it's usually the issue if you're seeing inferior wall MI. 1 and AVL are high lateral wall. They take a picture of the heart from up top on the left side, and then lateral wall side low is going to be V5 and V6. And if you see blockages in these areas, you're generally going to have some problem with the left circumflex artery. So this is the front view of the heart, and you're going to have a blockage in here, which would cause the blood flow to this area to be cut off V4 and V3, look at the anterior, so the front wall of the heart right here. This is what we're looking at with V4 and V3. And usually in the anterior, we're going to have a left anterior descending blockage. So somewhere in that vessel, and then you have a blockage down here, and now you have an affected cardiac muscle in this area. And V1 and V2 are your septal. So this is going to be looking at the center wall of your heart. 12-lead ECGs don't look at the right side of the heart, and the reason why they don't look at the right side of the heart is because most of the important stuff we need comes from the left side of the heart. There is a way to do a right-sided ECG, which is not going to be covered in this discussion, but for the most part, we're looking at the left side. So septal wall, if you have a septal wall problem, then you're looking at left anterior descending and maybe some of the small vessels that are coming off of there that would fill there. Not uncommon to have a anterior septal infarct where you have, V1, V2, V3, and V4 because the same area is covered by the same vessel. So you can take a pause at this point. We're going to end this section of the video. When we come back, we're going to talk about what a STEMI is, how to identify ST elevations, and how to deal with them when we've got them.